Okay, next section, arteriosclerosis. Arterio means arteries, and sclerosis means hardening. And so in this particular set of disorders, what happens is we get hardening of the arterial wall. Now this basically occurs due to thickening of the blood vessel wall, and there are three pathologic patterns. The first is called atherosclerosis, and in atherosclerosis we get a thickening of the intima of the blood vessel wall. That's high yield. In atherosclerosis, it's the intima that becomes thick, and this usually occurs in medium and large-sized vessels. So that's atherosclerosis. In arteriolosclerosis, the olo tells us that we're dealing with the arterial, so this will occur in small blood vessels, and we get thickening of the wall, either due to a deposition of protein within the wall or an increase in protein within the wall, and that's called hyaline arteriolosclerosis, or a hyperplasia of the smooth muscle of the wall, which is called hyperplastic arteriolosclerosis, but we'll give you some more details as we move forward. In Monckeberg medial sclerosis, you get calcification of the media of the blood vessel, and this is clinically not really significant. You'll hear about that at the very end of this lecture. So let's start with atherosclerosis. Again, remember, it's an intimal plaque that obstructs blood flow. So here's the blood vessel, and of course you've got an intima, you've got a media, and an adventitia. Those are your three layers, and this is an intimal plaque in which you get obstruction of blood flow. Now, important to note that this plaque mostly consists of a necrotic lipid core. So the key component here would be cholesterol, and it has a fibromuscular cap, as I've drawn here. And often, this necrotic lipid core can undergo dystrophic calcification, so it's not uncommon for atherosclerosis to be calcified. Here's a picture of atherosclerosis. This would normally represent the intima with an endothelial layer sitting on top of a basement membrane. Here is the smooth muscle media. You can clearly see that there's expansion of the intima by this necrotic lipid core. Notice all the cholesterol clefts sitting in the middle of this necrotic lipid core. And we've got this fibromuscular cap that overlies the necrotic lipid core. So again, intimal plaque that consists of a necrotic lipid core with a fibromuscular cap. This involves large and medium-sized arteries, as I've already mentioned, and the four most common arteries in the body to be involved are the abdominal aorta, the coronary arteries, the popliteal artery, and the internal carotid arteries. And the idea here is that when you get involvement of these arteries, you're going to develop certain pathology, and the pathology is what we're going to discuss in our both in this section and in the cardiac section. So the risk factors for atherosclerosis are actually divided into two, modifiable and non-modifiable. The modifiable risk factors include hypertension. That's a very important risk factor for the development of atherosclerosis. Hypercholesterolemia, for example, LDL increases the risk, whereas HDL decreases the risk. Smoking, and diabetes. So these are the four key modifiable risk factors that lead to atherosclerosis, and you need to memorize each of them. All right, so you need to know that there's four modifiable key risk factors: hypertension, hypercholesterolemia, smoking, and diabetes. The non-modifiable risk factors include age. For example, the number and severity of the lesions, they increase with age. Gender, for example, there's an increased risk in males and in postmenopausal females. Premenopausal females are relatively protected, and that's because estrogen is protective. And then there are some genetic factors. It's basically multifactorial, but important to note that family history is highly predictive of risk. The pathogenesis of atherosclerosis is debated, but one sort of theory is that you've got endothelium here. Of course, endothelium is sitting on top of this basement membrane, and the idea is that within this intima here, you get damage to the endothelium, which then results in lipid entering into the intima. And as lipid enters into the intima, the lipid then gets oxidized, and once it gets oxidized, it gets taken up by macrophages, so that you get collections of macrophages with lipid within them. That forms the initial lesion of atherosclerosis, which is called a fatty streak. And were you to look at a blood vessel in a very young patient, you could see these yellow flat streaks that are running along the large blood vessels, and those are called fatty streaks. They arise early in life, and actually they're seen in most teenagers. That's how early atherosclerosis begins. Now eventually you get inflammation and healing and increased deposition of this lipid within the intima, and that's going to result in a thickening of this lipid layer with a necrotic lipid core and the formation of a fibromuscular cap. Now that fibromuscular cap is due to the inflammation and healing, which leads to deposition of extracellular matrix and proliferation of smooth muscle. And so in the end, what's going to happen is that this is going to be the blood vessel, and you're obviously going to have this atherosclerotic plaque that will occlude the blood flow, or that will decrease the blood flow. Complications of atherosclerosis account for more than half of disease in the Western world, and let's walk our way through some of these now. The first is stenosis of medium-sized vessels, and here's the idea. If this is a blood vessel and it's going into an organ, you know that the medium-sized blood vessels are those vessels that feed the major organs. So let's say that this is the artery and this is the vein and this is the organ. If we get atherosclerosis here, then that atherosclerosis is going to cause stenosis of the blood vessel, i.e. you've decreased the luminal caliber of that blood vessel. And of course that can result in various signs and symptoms. So this can occur, for example, in the popliteal artery, resulting in peripheral vascular disease. It can also occur in the coronary artery, which would give you episodic chest pain or angina. And then it can also occur in the mesenteric arteries, which could give ischemic bowel disease. So that's complication number one. It's important to note that you usually don't get symptoms until you have greater than 70% stenosis. That's high yield. Greater than 70% stenosis before you actually get complications. Complication number two is plaque rupture with thrombosis, and the idea here is you've got this blood vessel, and obviously this blood vessel is feeding the organ. Let's pretend that you've got atherosclerosis here. Now, one of the complications of atherosclerosis is that at the neck, this is the place where it usually ruptures, at the neck, you can get rupture, which would then expose all of that necrotic lipid core. And if the necrotic lipid core and the tissue underneath it is exposed, that's going to result in activation of the coagulation cascade, and so you'd rapidly develop a thrombus here, which could then occlude the vessel, creating an infarction in this organ. And actually, that's the way by which a myocardial infarction occurs. It's usually due to plaque rupture with thrombosis. So the examples would be, if this occurred in the coronary artery, the patient would develop a myocardial infarction. If this occurred, for example, in the middle cerebral artery, the patient could develop a stroke. So that's a second complication of atherosclerosis. The third complication of atherosclerosis is plaque rupture with embolization. Now here's the idea. You've got this atherosclerotic plaque. It's possible for this plaque to break off, and then part of that plaque could embolize and go through the blood supply and then lodge in a distant site. And that's called embolization. Now that results in something called an atherosclerotic embolus. And remember that the hallmark of atherosclerotic emboli are the presence of cholesterol clefts. Now here's a picture of that. This is a blood vessel. This blood vessel contains an atherosclerotic embolus. And the way by which you know that it's an atherosclerotic embolus is because you see these cholesterol clefts. The fourth complication is weakening of the vessel wall. And the idea here is that, remember, the vessel wall contains an intima, it contains a media, and it contains an adventitia. And of course, this is where the blood would be present. Now remember that the blood vessel wall, i.e. the intima, media, and the adventitia, these are all alive, and they require oxygen in order to maintain themselves and to be healthy. Now normally, what's nice about the blood vessel is that the blood carries oxygen, and the oxygen from the blood actually feeds the entire vessel wall. However, if a patient gets atherosclerosis so that this intima becomes thick, it creates a diffusion barrier so that oxygen can't feed this wall, so this wall will become weak and will become atrophic. Now as the wall weakens, what's going to happen is you're going to increase the risk of ballooning of that wall, because now there's a weak wall with a lot of stress. And so the complication of that would be that you would develop something called a aneurysm, which is a balloon-like dilatation of the blood vessel wall. And so this is a fourth complication of atherosclerosis, and it's going to be very important as we move forward in this particular chapter. Now the second type of arteriosclerosis. Remember, arteriosclerosis is the global term that refers to these three mechanisms by which we can create thickening of the blood vessel wall. So the second type of arteriosclerosis is arteriolosclerosis, implying that we're dealing with the small blood vessels. Now what happens here is you get thickening of the wall of the small blood vessels, which then narrows those small blood vessels and then creates complications downstream. Arteriolosclerosis comes in two flavors. Number one, hyaline arteriolosclerosis, and number two, hyperplastic. In hyaline arteriolosclerosis, you get proteins leaking into the vessel wall. This produces vascular thickening, and you see it on microscopy as pink hyaline within the blood vessel. So here's what it looks like. This is obviously a blood vessel here, and you can see that the wall of this blood vessel is relatively thick, and what's thickening it here is the presence of this pink hyaline material. And so this is an example of hyaline arteriolosclerosis. Very important to note that it arises due to two things. You have to know this. This is super high yield. It's going to be something that we're going to hear about regularly as we move through pathology. Number one, benign hypertension. Patients who have long-standing benign hypertension, they get hyaline arteriolosclerosis. And the idea here is that the high blood pressure forces protein into the wall, giving us this change. And number two, we see it in diabetics. So patients who have diabetes, they get non-enzymatic glycosylation of the basement membrane, which then makes this blood vessel wall leaky, and then protein begins to leak in, giving us hyaline arteriolosclerosis. I cannot emphasize this enough. It's so high yield. It will come up over and over again in our discussions of pathology. Hyaline arteriolosclerosis is a consequence of two things. Number one, benign hypertension. Number two, diabetes. Now, the consequence of hyaline arteriolosclerosis is that you're going to get a reduced vessel caliber, which is then going to result in end organ ischemia. This can occur throughout the body, but it classically occurs within the kidney, producing glomerular scarring. And here's the idea. It's very high yield to be aware of. You've got this glomerulus here, okay, and there's an afferent arteriole here, and there's an efferent arteriole here. Imagine if you get hyaline arteriolosclerosis, so that you get thickening of the blood vessel wall. As you thicken the blood vessel wall slowly over time, you're slowly going to decrease the amount of blood that's actually supplying this glomerulus. This glomerulus will then scar, and you'll get something called glomerular scarring. So this is a key consequence of hyaline arteriolosclerosis. And in fact, this is the reason why patients with diabetes and patients with high blood pressure, they get chronic renal failure, because over time they develop this glomerular scarring due to the hyaline arteriolosclerosis. And that's what I've stated here in your text, where I say that it classically produces glomerular scarring. Now, when it produces glomerular scarring, we call that arteriolonephrosclerosis. Arteriolo, small arterioles. Nephro, kidney, sclerosis, you get sclerosis of both the glomeruli as well as those small blood vessels. And of course, this is how we get to chronic renal failure in patients with long-standing hypertension and in patients with diabetes. Now, of course, as you get this glomerular scarring, you're going to shrink the kidney, so the kidney will become shrunken, and on top of that, you'll see the scarring on the surface of the kidney. Now, when you look at the outside of the kidney, you're really getting a look at the cortex. So the outside represents the cortex. The surface of the kidney is really up against the cortex, basically. And so this is a classic example of arteriolonephrosclerosis. The other type of arteriolosclerosis is called hyperplastic arteriolosclerosis. And again, this is going to involve the small blood vessels, and we're going to get thickening of the small blood vessels. However, instead of the thickening being due to this protein that's leaking into the vessel wall, we get hyperplasia of the smooth muscle that results in that thickening, which then gives something called an onion skin appearance. So here's the classic image, and this is again a small blood vessel or an arteriole, and we've got thickening of the arteriole, and you can see that there's too many muscular cell layers here, and that's producing layer after layer of smooth muscle, which then is called onion skinning because each layer looks like the skin of an onion. Now this reduces the luminal caliber, which then decreases the blood flow going to the end organ. All right, once you've understood the histology, then the next question is, what is this process due to? And it's very important to note that this process is a consequence of malignant hypertension. Malignant hypertension. And so the idea here is that when you get super high blood pressure, sort of the smooth muscle begins to respond by hyperplasing, almost trying to contain that high blood pressure. And so that's called hyperplastic arteriolosclerosis. Now, of course, the luminal narrowing that's going to occur here is going to result in reduced vessel caliber, and so we'll get end organ ischemia. Now, that high blood pressure can also result in fibrinoid necrosis. Remember from Chapter 1 when we talked about necrosis, we said that when you get death of the blood vessel wall, that's called fibrinoid necrosis, and we see that in two circumstances. We see that in malignant hypertension, and we see that in vasculitis. So this is an example of where we might get fibrinoid necrosis of the blood vessel wall. Now, the classic finding is also present within the kidney when patients have hyaline arteriolosclerosis, and that is that they get acute renal failure with something called a flea-bitten appearance to the kidney. The acute renal failure, again, is because you're getting acute damage due to the very high blood pressure to the kidney. And at the same time, you get this flea-bitten appearance because on the surface of the kidney, you have these little pinpoint hemorrhages where you've had blowing out of the blood vessels, for example, which then results in hemorrhage. So this is a very high yield principle to be aware of. Now let me just summarize this because the entire discussion is so central to so much of pathology. Basically what we've said so far in these few slides that we've covered are that you can get thickening of the blood vessel wall, and when you have thickening of the blood vessel wall, that's called arteriosclerosis. If you get thickening of the large or medium-sized blood vessels with an intimal plaque, that's called atherosclerosis, and that will have 4 complications, which we've already discussed. And then the other possibility is that you can get thickening of the small arterioles, and that's called arteriolosclerosis. Arteriolosclerosis can be divided into 2 types, hyperplastic and hyaline. In hyaline arteriolosclerosis, you get leaking of protein across the blood vessel wall, which thickens the blood vessel wall, giving it a pink appearance. And of course, the 2 ways by which you can get hyaline arteriolosclerosis are hypertension, which squeezes protein across that blood vessel wall, and diabetes, in which you get non-enzymatic glycosylation of the basement membrane of the vessel wall, which then allows protein to leak in. So hyaline arteriolosclerosis, benign hypertension, and diabetes. The other way by which you can get arteriolosclerosis of a small blood vessel wall would be hyperplastic arteriolosclerosis. This is where you get thickening of the blood vessel wall due to hyperplasia of the smooth muscle, and it's classically seen with malignant hypertension. You've got to have all of that summary very well established in your minds to be able to understand the discussions that we're going to have as we move forward. Now the third way by which you can have arteriosclerosis would be a disease or a disorder called Manka-Berg's medial calcific sclerosis. And the idea here is that you get calcification of the media. That's why it's called media, and that's why it's called calcific, calcification of the media. Now, this is non-obstructive, and therefore it's not clinically significant, all right, and it's seen as an incidental finding on X-ray or mammography. This is what the histology looks like. You see a blood vessel wall. This layer here represents the intima. You can see the intima is right up against the smooth muscle media, as it should be. And then within the media, you can see that you've got this area of calcification. So this is Manka-Berg's medial calcific sclerosis. Again, it does not alter the luminal caliber, and therefore it does not affect blood flow, and therefore it is not clinically significant. The only reason you need to know about it is because it can show up on X-ray, in particular on mammography. Now you know that on mammograms you're classically looking for calcification as a sign of cancer. Remember, that's one of the things that we screen for, is the presence of calcifications. And so it's important to note that you can also get calcifications of the blood vessel wall. And so this is an example of a calcification that's running in a vascular pattern. And so this is called Manka-Berg's medial calcific sclerosis. It's important to note that that would then result in incidental calcifications on, for example, a mammogram. And that closes off this particular section.